di PubMed dan juga Scopus, dan merupakan anggota aktif di beberapa organisasi profesional. Over to you, Prof. Iko.
Terima kasih Daniel. Thank you very much. So good afternoon, everyone. So I think we welcome you to the second session today. We are very pleased to have Professor Fatemi here. And then this session is very special because we can asking everything to Professor Fatemi. But please don't asking about your faith to the Fatemi. So without further ado, we invite Professor Fatemi to come forward to the stage. Yeah, everyone knows. I think this morning we have already listened Professor Fatemi lectures about individualized and precision medicine in assisted reproductive technology. So Professor Fatemi is a group medical director at ART Fertility Clinic. Yeah. I think this the theme of our discussion this morning about the precision medicine in ART. So Fatemi, I think we are very all of us know that based on the Pasquale Patricio publication, I think it's 10 or maybe more than 10 years ago, that only 5% of all sites, 5% of all sites is coming to the live birth. So that's why IVF right now is in the era of precision medicines. So very important for us to get normal, a good euploid oocyte, and then also a good euploid embryos, receptive endometrium to get our patient pregnant. So first of all, in the first part of our discussion this afternoon, we are trying to make a discussion about ovarian stimulation, because to get a good oocyte, we should make a good ovarian stimulation. And then if we talk about the ovarian stimulation, we talk about gonadotropin, we talk about FSH. And then a long time ago, Klaus Hiding Anderson published about the concept of isoform of polytropin, isoform of gonadotropin in our body. That's very important if we plan to do ovarian stimulation. So what do you think about the concept of isoforms, polytropin in control ovarian stimulation?
So absolutely. I mean, there are different isoforms of FSH which are present. So there are isoforms of FSH, and as you have seen, what I have highlighted during the presentation, these isoforms are based on the acidity of that molecule. Yeah. So when you have an FSH molecule, that FSH molecule has 4 arms. And based on how many sugar residues you attach to these different arms, you increase or decrease the so-called isoelectric point, IP. And this change of acidity has an impact on the half-life time of that molecule. But that's not the only variable which is changing. It also has an impact on the affinity to the receptor, yes, and post-receptor activation. So there are a couple of variables which need to be put in this equation in order to have a better understanding. But I'm fully aligned with Klaus Hiding Anderson's publication. I respect him a lot as a scientist, because he really highlights the weaknesses that we clinicians don't see. You know, Klaus himself is an engineer. Yes. He is an engineer, but he sees things that we don't see. And I really respect him a lot for what he has published and what he has contributed in our field.
Okay. So if we look the natural cycle, in menstrual cycles, physiologically during every month in the menstrual cycles, in the beginning of follicular phase, the isoform that's secreted by pituitaries more likely is more acidic. And then at in the late follicular phase, followed by less acidic isoform. So with this concept, do you think it's very important if we, in the future or in the near future, if we plan to do the control of stimulation, we following the natural cycle? You mentioned that back to follow, but we should learn from the natural.
You see, the problem here is you're absolutely right to describe the different pattern of isoforms during a natural cycle. You're absolutely right about that, starting with a high acidity going towards a lower acidity. But it's not all or nothing. It's not all or nothing. So basically, it is majority more acidic, minority more basic, and somehow mid-cycle it switches. Then you go towards one is more than the other is less. But the thing is, you know, when we stimulate, we don't have a monofollicular growth. We have a multifollicular recruitment.
Yes.
And the difference here is that the dosage is different, the pattern of FSH is different, the follicular recruitment is different, but I think the concept should be high down, because this is what nature is doing. But there is here, in the concept of, I didn't want to make it too complicated, so this is, I didn't go too much into detail. But let me ask you a question. The cause that progesterone goes up in a natural cycle, because before ovulation, you have a little bit of progesterone rise, okay? Why is that happening? Why? Because I mentioned FSH creates LH receptors. So LH receptors are being created, but then FSH goes down. But the body gives a signal, I have created enough LH receptors. So once there are enough LH receptors, you have a little bit of progesterone. And that progesterone is a sign, okay, I'm ready to go, because now I have enough receptors. And this progesterone is 0.5, 0.6. It's not a lot. It's not a lot. On the other side, if you do this step down too early and you have created your follicles and your progesterone levels are too low, that's also not good. That's also not good. Because if you have a follicular recruitment, but you don't create enough progesterone receptors, LH receptors, which is leading to a little bit of elevated progesterone, you will end up with a lot of immature eggs. So it is not that step down with all is good. No. You need to create a certain follicular dynamics. You need to have a certain number of LH receptors that reflect
cells.
Exactly. And that will be reflected in the systemic progesterone. You know, Christophe Bloquel published, I don't know, when we were kids, I'm saying about 20 years ago, a paper where, I don't know if you know that paper, he published high progesterone is not good and low progesterone is not good. At that time, we did not understand why low progesterone is not good. But today we understand, because if you have too low progesterone, most probably you did not create enough LH receptors to have a correct final oocyte maturation.
Okay, thank you very much. It's very, very clear, your explanation. So back to our daily practice. So now we have available commercially available the more acidic and then less acidic of isoform of gonadotropin. So what do you think? Which one is the best? In order to get our patient get pregnant, so which one is the best choices for us? Is less acidic part is recombinant gonadotropin, or more acidic part most likely right now is dominantly by urine product, and now there is a new product for gonadotropin that more acidic. So what do you think?
You know, it's like you ask me, is a Porsche Turbo S better or a Ferrari? It's based on a driver. So a simple answer is based on who is driving it, okay? And which roads are you driving? So that is important. Now, if you ask me, is recombinant better or urinary or whatever, I think there is no answer to that. I can give you a full presentation where I can tell you urinary is much better. And half an hour later, I'm going to give you a presentation where I will tell you exactly the opposite. So this is the problem, that there is a lot of bias created by pharma companies.
Okay.
Now, to answer your question, I think all these drugs have their efficacy and efficiency, but it is based on how they are used. What we know for sure is that recombinant products are pure. We know that what you give is what it is. That's what you know. And this is one of the slides I also use, but due to time restrictions, I didn't go into detail. With the urinary products, you don't know what you are giving because there is batch-to-batch variation. This is the first question. Now, imagine there are many studies comparing urinary FSH with recombinant FSH, right? I'm going to ask the audience, if you see a study comparing, for example, HMG with rec FSH, how many variables do you have? How many variables do you have? What do you think?
It's a lot. Yeah.
Sorry?
So if you're comparing the
HMG with rec FSH,
yes.
how many variables do you have? Because if you want to do a study, you want to have one variable. And if you have a difference, you say, because of that variable, I have this difference, right? So let's say you compare HMG with rec FSH. How many variables do you have?
Live birth, for example.
No.
Pregnancy.
Between these two products, how many variables you have? One variable?
Many.
But how many, Ivan? How many? Let's start with number one. Urinary FSH versus recombinant FSH, right?
Yes.
Good. It means we are having different FSH isoforms. This is one variable. Good. The second variable is this urinary, the dose that you give is not the dose that you give because you have batch-to-batch variation. So this is the second variable. What is the third variable? Presence of absence of ACG, right? Good. So we already have three variables. What would be the fourth variable? What time they were administered? Were they administered at the same time or different timing? Right? Good. So you already see you have four variables. Now, if me as a company say, yeah, because of that, this and this happened, and this is the explanation, I'm totally wrong because I don't know which variable is responsible for that. First, I need to understand that this recombinant FSH has higher affinity for the receptor. We know that, right? We know that it has a different post-receptor activation. And I know if I push too much and I don't check my endocrine profile, it might be detrimental because I'm doing a wrong job. So when you ask me recombinant this or that, I don't think that there is a clear answer because there is not a single study which was done correctly in order to answer this question. But if you ask me personally, do I refer one over the other? I would tell you no, as long as you stimulate correctly. And I think recombinant FSH is potent. It is targeting the receptors correctly, but you need to stimulate correctly. That's very simple.
Okay. Yeah. Okay. Thank you very much. And then if you look now, there's also the recombinant with more acidic. Available right now in the commercially available. So what is your opinion if you compare the same recombinant FSH, the one is less acidic, the other one is more acidic, and then do you think that in the more acidic recombinant is more appropriate if we want to use in hyperresponder patient in order to avoid ovarian hyperstimulation syndrome, something like that? What opinion?
So just to clarify your question, that I think everyone understands the question correctly, what you're asking me is polytropin delta versus polytropin alpha. Is this your question?
Yes.
So just to express it the way it is, polytropin delta versus polytropin alpha, there have been studies mainly in Asia, Asia. And a couple of slides I showed you. Now, polytropin delta has been assigned to be started based on AMH, right?
Yeah.
Good. Now, if I ask you, what is producing AMH? What is producing AMH? What would you say?
Is it granulosa cells that the
Granulosa cells, yes. Of which cells? Which follicles?
early antral follicles.
Early pre-antral follicles, right? Good. Now, what about antral follicle? 6, 7, 8 millimeters. Do they produce AMH or no?
No.
No. Okay. I have to disappoint you. 80% of AMH is produced by antral follicles. So a follicle of 7 millimeter produces. Now, if you have that and you have high levels of AMH produced by antral follicles that you can see, and you have 25% of intercycle variation, I want to know how we can rely on AMH. This is number one. We published a paper with Laura Belado on intercycle variation of AMH, and together it's around 50% variation that you have. So you start up with a shaky value because you don't know if this value is reliable. And I'm not talking about inter-assay variation. I'm just talking about basic physiology. This is number one. Number two, the so-called GRAPE study, and whatever you give a name for it, you have one group of patients which is personalized and which is treated according to a certain value, and another group of patients which is not personalized and not identified based on the patient's requirement. So here you are already, your starting point is not correct because one is individualized, the other one is not individualized. And as I mentioned previously, it's not only the starting dose which is important, it is also dose adaptation which is important. So I think many of these studies, unfortunately, have a lot of shortcomings. You see, people who work with us in our clinics, and today we have around 500 people working for us. In the beginning, where they come, they say, yeah, we know everything and that and that. After 3 months, they all start crying because we have to reset whatever they know. And most of these people, when they go to major conferences, they laugh with most of presentations because of the shortcomings, exactly these kind of shortcomings. You see, in our field, we have a tunnel view. We have one question, we look to one answer, but we neglect everything around it. And I think that is a shortcoming. Is it now FSH? Is it time to trigger? Is it genetics? Is it mosaicism? Is it endometrial receptivity? Every aspect, we need to take one step back and to have a more holistic approach. So when you ask me about OHSS, honestly, personally, the last 6 years, I have not seen a single OHSS, not a single OHSS, because it does not exist. It does not exist anymore. So my concern is not OHSS because I don't see OHSS. My concern is to have a pregnancy. My concern is to have good egg quality, good embryo quality, and a healthy child. That is my concern.
Okay, yeah, thank you very much. So if we think about the precision medicines in the field of ovarian stimulations, individualized ovarian stimulation, so what kind of variable that is very important to determine our initial dose of stimulation? So do you think that like polytropin delta only based on AMH and body weight it's enough, or we should also including the genetics? You mentioned a lot about genetics. What do you think?
Yeah. So, you know, we published in fertility sterility, I think 2 months ago, a paper. Laura Melado is the first author. And just briefly describing to you what it was. So this was a patient. She was, I think, 34, 35 years of age. She was referred to me as being in a menopause because she had no period. I did a scan with her, and she had a PCO aspect, PCO right, PCO left. And I said, maybe it's AMH was less than 0.01. I said, maybe it's an assay problem. So we run again the AMH because the AMH should have been 5 or 6 nanogram because she had a lot of follicles. It came out at, again, 0.01. So I said, okay, we have a lab with which we collaborate in the US, in Texas. What they do, they use different assays. So we use different assays, and still it came out below detection level. So the patient was PCO at normal levels of FSH, normal levels of LH, PCO, but AMH below detection level with every assay you have in the world. There was not a single assay which was capturing it. So then we said, okay, let's have a look why. We did a whole exome sequencing, And it came out that she has a defect in an amino acid where all these assays don't capture that. Okay?
Yeah.
So imagine that patient, and we published that, that patient would be treated based on AMH. She would have been killed because it was a PCO patient. What I want to tell with you, you cannot rely on AMH. First of all, because of intercycle variation. Secondly, because the basal FSH is the biggest predictor of your response. So we published a paper. I presented it very fast again. Raquel Delgado is the first author. It was published 2 months ago in RBM Online, where we look specifically to FSH. So for us today, AMH is not a tool. We do that for research purposes, but we don't do that for clinical utilization. By the way, we use AMH for male infertility because we do a lot of microtesticular biopsies, and we use AMH for male infertility. But for female infertility, we are focusing more and more on the FSH level because that is a reflection of the receptors of the response of the patient and aneuploidy, independent of AMH, independent of age. The higher your FSH is, the more aneuploidy you create.
How about the L8 polymorphism?
Very good question. Thank you for that. So also LH receptor polymorphism is extremely important, and sometimes they go parallel. Sometimes FSH and LH receptor polymorphism go parallel. But then you see with these patients that they have also elevated LH, look like a PCO aspect, but it's not a PCO, but you have high LH.
Yes.
Now, those patients are very difficult because you let them grow, they have big follicles, you give the trigger shot, and you end up with GVs or no eggs at all. And sometimes if you have 1 or 2 mature eggs, M2, and the rest are M1 or GVs, even these 2 M2s are of bad quality. Why? Because they have nuclear maturation, but they fail to have cytoplasmic maturation. So with these patients, it's funny what I'm going to tell you, but purposely, we let progesterone go up. So these patients, we want to create more LH receptors. So we let the progesterone go up during the stimulation because this is a sign that we have created more LH receptors. And then we let them become very big and we trigger them. And this is, again, it's not one size fits all because you cannot say do this or do that. It's much more complex. Everyone is different and everyone should be treated differently.
Yeah. Thank you very much. I think the audience, if you have a question, please asking directly. And yeah, go to the microphone and then say your name. Maybe you can also asking about the case in your daily practice about open simulations. Yeah. Okay, while waiting, what do you think, Fatemi, about in the near future? Do you think there is the long-acting gonadotropin? Do you think it will be useful for our patient in order to avoiding stress during the stimulation?
So just to elaborate over the long-acting, so the long-acting it was developed about 20 years ago. And when I was in Brussels, I published many papers on that topic. So what is a long-acting? The long-acting is the basic FSH. And they took the 28 amino acids of ACG and attached it to the FSH. It's called corifoliotropin alpha. It has a long-acting working. And yes, we use that. And basically, we are running currently a couple of studies with that in order to have one injection without any antagonist.
Yes.
Without any antagonist. And we started in the luteal phase in order the high progesterone of the luteal phase would prevent the premature ovulation. So basically, you reduce the number of injections significantly. So we're running a study currently, and hopefully we will be able to answer it. But yes, I think we published a couple of papers in FNS a few years ago. It's working, but you have to be cautious with high responders because if your AFC is more than 10, you should not use that. And also there are different dosages. So I have an abstract at ESHRE this year, actually, where we published data on different dosages of this drug. So there are 2 dosages available, 100 and 150 microgram. So what we did the calculation because 33% of the patients will be ready on day 8 and 70% will not be ready. So in order to reduce the number of injections, what we did, we said, okay, let's reduce the dose of the second injection to half or less than half. So go to maybe 25 microgram or 12.5 microgram. And just based on the size of follicles, just give a second dose. So basically, you can finish the whole stimulation with 1/2 injections. Yes, these are ongoing studies, which hopefully we can answer in near future.
Okay, thank you. Dr. Anam, please.
Thank you, Prof. Wiweko. Thank you, Prof. Fatemi. I'm from Bali. I have some cases about SLA, yeah. Because we know there's SLA after the treatment, the condition is premature ovarian insufficiency. The problem is if FSH is so higher, the estradiol is so less. And we start in this case SLA with the IVF because estrogen is affect about the risk of the flare the patient. So I start low, but after that the response is not so good. And 2 cases is we fail for that. What's the tip and the trick? We have some patient with the SLA like that. Thank you.
Tip and trick for FS.
Tip and trick for
SLA.
lupus.
Yes,
Ah,
yes.
systemic
Lupus, yes.
I mean, with these lupus patients, obviously it's an autoimmune deficiency or autoimmune disease, which might also impact the quality of the oocytes. Obviously, you need to see that the follicles are synchronized. You need to see that you have enough FSH receptors. You need to see what is the basal level of FSH, because that basal level of FSH will be also a reflection of your stimulation. And if you see that these patients are suboptimally responding, what we do sometimes, we give them androgens in order to increase the number of FSH receptors. So you can pre-treat them with transdermal testosterone, you can give them DHEA in order to increase the number of FSH receptors. And again, there have been publications that in poor responders, that doesn't help, but I'm not talking about the poor responder. I'm talking about this group of patients who are suboptimal responders. So most likely with these patients, pre-treating them to enhance the FSH receptors might help. And then you have to see, and this is something, again, it was neglected, you know, and I don't know if the message was clear, what I mentioned previously. You see, when we say, I give 150 of FSH, or I give 300 of FSH, or I give 600 of FSH, it is not what you give. It is not what you give. It is how much of what you have given is active in the circulation. You know, I mentioned previously, ESHRE says 300. We have cases, we gave 300, the basal FSH is 8, after 300 is 9. Just 1 unit difference. We have patients, we give 150, and after 6 days is 25. So it is not what you give. It's very simplistic to say, okay, Poseidon is the same thing. They say, okay, I expect a good response. I give, nothing happens. Yeah, but what was your basal FSH? Maybe they have an FSH receptor defect. Maybe you gave 200 and your systemic was only 8. Maybe if you would have given 400, your systemic FSH would be higher. You would have had this recruitment. I think at the end, all these details will have an impact on your follicular recruitment.
Dr. Anam?
Thank you, Prof. Yeah, thank you, Prof.
In the lupus also, this is such a patient that we should avoid the high level of estradiol, right?
Absolutely. Yeah. I mean, you need to avoid high level of estradiol for obvious reasons and complications. For example, one tool to keep it low is like you are treating a breast cancer woman. You see, you can combine the treatment with letrozole. So you stimulate them with FSH and letrozole. As you know, letrozole is an aromatase inhibitor. It prevents your estradiol production, but accumulates the androgens. And those androgens would enhance and increase the number of FSH receptors. Hence, you would have, with one shot, you kill 2 flies, because first of all, you keep the estradiol low. Secondly, you increase the number of FSH receptors.
Okay. If anyone have another question, please. Yeah, Dr. Ivan, please. Microphone.
Don't ask me about the cows, Ivan. Huh?
Mike. Not running.
Thank you. I won't ask you about the cows. But I think it's interesting that we see the development of fertility word seems like we're going forward and going backwards and forward and going backwards again. It seems that we have learned in the past that FSH and LH ratio, it doesn't really exist in the way that we're modeling our stimulation regimen. If you look at the recent paper, I think in RBM Online recently about the late follicular stimulation, where we see there's no difference of the quantity and the quality of the oocyte produced by that. And start to question whether are we actually measuring the FSH primarily on the process of recruitment during the initiation of the cycle, or more towards part of the process within the cycle itself. The FSH would be our surrogate information for the potential cycle that we're intending to stimulate. What do you think?
So thank you for this comment, Ivan. You know, there is a beautiful work from the Netherlands, which was published in Human Production Update. It's a part of Bart Fauser's group, I think 25, 30 years ago, where they describe the so-called follicular recruitment. There are different theories, and we don't know which one of them is correct. But if you look to basic physiology, what is happening, when I was doing my PhD in the luteal phase, we did a lot of measurements of hormones during the luteal phase. And something I didn't understand, you know, when you have an ovulation, obviously your progesterone goes up. When the progesterone goes up, the estradiol drops. So you have a drop of estradiol, progesterone goes up, which is logic. But on day seven, after the ovulation, when the woman is not conceiving, you see estradiol going up again. In the beginning, I did not understand why this is happening, because why is estradiol going down and then estradiol going up again? The reason is that FSH starts to work to recruit the follicle for the subsequent cycle. So your point is a very valid point, because even when we measure the FSH on day 2 or 3 of the cycle, it might already be late because you are already at a stage where the dominant follicle from the previous cycle has already been recruited. So what would be the best timing to measure an objective value of FSH? I think personally, I might be wrong, is the moment nature makes estradiol going up again. And that is mid-luteal. So that is in the middle of the luteal phase of a previous cycle. So most probably at that time, you would have the most objective measurement of FSH to understand what's the quality, what I'm going to get. Obviously, we follow a dogma and we always do day 2, day 3, and we measure what we have learned 20 years ago. But what you say is absolutely correct. So most probably a correct way would be to measure the FSH on day 7 in the luteal phase to capture the ovulation. And this is a part of the study that we are currently doing. You know, currently we are doing a study based on what you were asking previously with long-acting FSH, that we say, look, we're going to create the recruitment when nature starts to recruit. So in order to wait on day 2 or 3, or random start, or start in the luteal phase after ovulation or 2-3 days before they ovulate, maybe we should go towards the mid-luteal phase when nature starts the recruitment, do this, what nature does, but at a high level, and then go gradually down and see what would be the harvest that you would get at that point. But you see, we need to rethink everything we have learned, because now, obviously, we are at a time of random start. Anytime you can start luteal phase. On the other side, we have a paper, which is under review in Human Reproduction now. And we have another invited paper, which actually I corrected in the plane when I was on the way to here. It's an invited paper on the luteal stimulation. Something people don't talk about is natural conception, why you stimulate them. So we have had, I think, 7 or 8 pregnancies during the luteal stimulation. Yeah. So also there we have to be cautious.
Yeah. It will be very different and varied according the patients, whether they have a third wave, a second wave, or 2 wave or triple wave of the follicular genesis, right?
Absolutely. And you know, also this wave theory, it's just a theory. You know, these 3 waves, it's just a theory. Whether it is fully correct, I don't know. I don't know. And that's also what Bart Fauser says. I mean, he was working on that.
Okay, thank you very much. So I'd like to continue with the ovarian response during the stimulation. If we compare the folitropin alpha and delta, the one with IU, the other one with micrograms, and then the paper published by Garcia Velasco explained that the response with the 10 microgram is correlate equivalent with the 150 IU in folitropin alpha. So what do you think? What is your opinion about this?
You know, it's the same answer I gave previously, because one group you treat based on a certain value of AMH. The other group, you start a fixed dose without individualization. I think the key answer is you need to individualize according to the patient's profile that you are treating. If you don't individualize, or you overtreat or you undertreat. And I think that's the wrong concept. You need to make sure that your starting point is equal, and then when you treat them, that you treat them equally. And if you are over or under treating one group, your results will not be correct.
So I think we should be very careful about it. Right?
Absolutely, absolutely. Personally, I don't rely on AMH. I don't rely on AMH because we have had so many publications on unreliability. We do that for research purposes. We do that a lot for research purposes, but my clinical judgment, I always say what you see is what you get, antral follicles. Number 2, your FSH levels. I believe more and more on the importance and the value of a completely neglected hormone, which is FSH. You see, sometimes when new things come out, you say, okay, this is cool because this is new, but we forget the old. But old is not always bad.
But do you believe about the mechanism action of AMH in the preantral state that inhibiting recruitment of the follicle?
Absolutely, absolutely. So the AMH is there to prevent that the patients would recruit 1,000 follicles. And actually, at some point, we had this idea to use anti-AMH for poor responders. Because if AMH is blocking very small follicles to be recruited.
Yes.
But if you would have developed an anti-AMH, you could possibly treat poor responders, because poor responders, it's not that they don't have any eggs. They have, but they're not recruited. So what you could do, instead of having 1 or 2 follicles every month, maybe you could recruit the follicles for 1 year in one cycle, that you have 15 or 20 follicles being recruited. And that might be a solution for the poor responders, which should be done in future, hopefully.
Okay. Also on the other side is the PCOS patients with the very high level of AMH. The AMH also inhibiting the aromatase activities during the antral stage. So do you believe for that?
Yeah, of course. I mean, this is what is happening. So they have a hyper recruitment of the follicles. So this is why they have a lot of follicles, but they are interfering with each other, so they are not ovulating.
Okay. Okay, we continue to the next questions about the implantations, and then about the endometrial receptivity as well. So, do you think is there any opportunity for us for doing fresh transfer instead of frozen embryo transfer?
I will tell you my own personal opinion. I think we should, if you rely on your lab, you should not do fresh transfer. That's what I think. On the other side, will patients get pregnant with a fresh cycle? Of course they do. There is a beautiful publication from US, from Las Vegas, where they looked into which patients get pregnant fresh, which patients get pregnant in a frozen cycle. Now imagine the endometrium of a patient who is stimulated is always advanced.
Yes.
So endometrium of a patient who is stimulated is always advanced. Because multifollicular recruitment, trigger shot, progesterone up, and it's advanced. An embryo which is developing fast, so embryo is fast, endometrium is fast, they will catch up and there is enough. Let's say endometrium is fast, embryo is medium. If you're lucky, it will implant. If you're not lucky, it will not implant. But if the embryo is developing a little bit slower, you fall out of the window of implantation. So most probably, fast developing embryos, good quality embryos will implant. But a little bit slower developing embryos will fail to implant. On the other side, if you have the feasibility of putting back that embryo in its natural habitat, which is a natural cycle, without all these hormones, why should you not? Why should you not? Yeah. Of course, the next question would be, what preparation of the endometrium would you prefer? Do you go with HRT, natural cycle? But that's a different topic.
Yes. Thank you very much. So any questions about it? Please come to the microphone and then say your name again. Yeah. Okay, please.
Thank you for the chance for asking. I'm Edwin from Bandung. My question is regarding the FSH monitoring. When is the best time to monitor the FSH level during the stimulation? And what strategy do we have for the over FSH and the low FSH to survive or to salvage the cycle? Thank you.
Thank you for the question. That's an excellent question and a very difficult question to answer. So short answer is we are currently working on an artificial intelligence model to find out, because everyone is different. Longer answer, you know, when you stimulate a woman, we always give the FSH at the same time. We always give it at the same time, again, for research purposes. So we give the FSH at 7, 8 p.m. We give the antagonist always in the morning at 7 to 8 a.m., always. And we measure the blood around 9 to 10 a.m. So in order to be completely in one line without any variation that other people have published, okay? Now we know that if you reach a systemic FSH of 23, 24, you have covered most of the receptors, if not all the receptors. And we know that follicular growth is a dynamic process, okay? And every follicle is different, every woman is different. And the problem is the more you know, the less you understand things. You see, the more complicated things become. I wish I would be on the level of 20 years ago because life was very simple. You see now what we do, we measure the basic levels, day 2 or day 3. Of course, we have antral follicle count, we have FSH, LH, progesterone, estradiol. Normally, the progesterone on day 2 or 3 of the cycle is low. So normally, it is 0.1, 0.2 nanogram per ml. And if your lab tells you it's 0.6, 0.7, you go to the lab and you shout at the guy, say, you are giving me wrong results, unless the patient has adrenal cortex hyperplasia, okay? So the value, the basic value is 0.1, 0.2. Now, when you stimulate a patient, the follicles grow, and you see back the patient on day 6 or day 7. If you see you have, let's say, 15 follicles that are 13, 14 millimeters, that are growing, you gave your antagonist, you see your estradiol goes up maybe 800, 900 picogram, which is good, but your progesterone went from 0.1 to 0.9 in 5 or 6 days. And your FSH is 25 or 30, right? What would you do? Because your FSH is high, the follicles are growing, but your progesterone went from 0.1 to 0.9. But you're not ready yet because you still have 2 to 3 days to go, right? So if you would have continued with the same dose, I can tell you, after 2 to 3 days, your progesterone would be 1.8 to 2 nanogram, okay? But if you say, okay, my FSH is 25, progesterone went from 0.1 to 0.9, my E2 is good, but FSH is 25, 27, then you start stepping down. On the other side, let's say you start, your follicles are growing, FSH is 25 or 24, and your progesterone is 0.1, 0.2. Estradiol is going up. You don't need to step down. You just continue with the same dose. Okay? So it's not only the basal, the FSH level, which is important, it is the patient's response, which is important. But the patient's response is also based on her own physiology. It's based on her metabolism, number of receptors she has, right? So, and this is why it's not one size fits all. You need to take all these variables into cohesion in order to take a meaningful decision. Because if you do a step down too early, even your follicles might grow, but you might end up with a lot of immature eggs because you didn't push with enough FSH to create enough LH receptors. I hope it's clear because it's very complex.
Okay, yeah, thank you very much. Once again, Fatemi. So now we talk about the role of progesterone in preparing the endometrium, especially for frozen embryo transfer. I think many paper mentions Labarta about the serum progesterone in frozen embryo transfers. So what do you think about this? This is even it's very inconclusive. Yeah, I know you mentioned a lot in the paper. There is no correlation with the serum progesterone or tissue progesterone. Even in the era receptive state, there is no correlation with the serum progesterone or progesterone in the tissue. So what do you think about this?
So I have to be politically correct now with this answer. So personally, again, we published a paper with Barbara Lawrence in Human Reproduction, I think 6 months ago, maybe 1 year by now, where we indeed describe that it's not one size fits all. Because people say, okay, if it's not 9.2 nanogram,
Yes.
I will not do that. If
Yeah.
it's 9.1, I will do this. Honestly, I think it's ridiculous. I think it's ridiculous. Because Christophe published a paper a few months ago. You see, 9.1 or 9.2, how many hours after you gave the progesterone? Because if you measure after 3 hours or after 6 hours, there will be a variation. It could be 9.2, it could be 6.8. So this is the first thing. The second thing, and this is a thing which has been neglected completely, but completely. And if I tell you, you will say, why did you not think about that earlier? Now, what is creating the progesterone receptors? What is creating progesterone receptors? It's your estradiol, right?
Yes.
So the estradiol level of the follicular phase is creating the progesterone receptors. So the higher estradiol levels you have, the more progesterone receptors you create. Good. There is a paper which was published very recently by Peter Humeidan, Fertility Sterility, where they didn't look to progesterone. They looked into estradiol values. So it seems that estradiol values are as important as progesterone values. But one thing no one ever did, and we are working on it currently, to put all of them together. To look to the estradiol level in the follicular phase and link that with the progesterone level of the luteal phase. Because it would make sense if you have high levels of estradiol, you would need more progesterone. Because you have more receptors, you have to cover these receptors. If you have medium or lower level of estradiol, you don't need to give that much. You see? It's the same concept like endometriosis or adenomyosis patients. These patients, they have aromatase activity, they produce a lot of estradiol, they have progesterone receptor resistance, hence they would add more progesterone to the luteal phase. So it's the same concept. Obese women, aromatase activity, higher estradiol, more progesterone receptor resistance, they need to have more progesterone. So I think also that value is not correct. I think you have to think which value is good for whom. Then you have to look to the demographic of the patient. You have to look to the estradiol value. There is a publication from Paris, Human Reproduction, last year. I don't recall the first author, but they said if you have high estradiol in an HRT cycle, your pregnancy rates drop. But this is because they did not compensate the luteal phase correctly. Most probably high E2 in the follicular phase would require high progesterone. And this individualization should not be based on the value of progesterone in the luteal phase, but based on the value of the E2 of the follicular phase. Needs to be linked together. And to make it more complicated, I don't know if you do a lot of HRT cycles, right?
Yes.
So if you do HRT cycles, do you measure sometimes your LH value? No. So we measure LH, again, for research purposes. 30 to 40% of patients will have an LH rise without a follicle, without a dominant follicle, simply because of high estradiol, pituitary, LH rise. So another issue would be, if you have an LH rise, will this have an impact on your outcome? So it's not only the estradiol, It is estradiol, endometrial thickness, LH rise, and the correlation between the genetics of the embryo and the progesterone level you have in the luteal phase. So you see, there are so many variables, but again, we have a tunnel view. What do? Okay, we look at progesterone. It's not the progesterone. It's many other things which are correlating with each other.
So which day you check the LH in the HRT cycle?
The day we start the progesterone, before we start the progesterone.
Before.
And we see around 33% of women, they have an LH rise.
And then you cancel if the LH is...
No, because there is no follicle.
Okay.
There is no follicle. They just have an LH rise because estradiol is high.
Okay.
So we are analyzing the data to see if this LH rise has an impact on the outcome. I don't think it has an impact. I think it's more the E2 level, which is important in correlation with the progesterone level.
So right now in your current practice, most likely you did by HRT cycle or natural cycle?
No. So we published the first natural cycle transfer and superiority of it in 2011 in fertility sterility. So since then, we are big promoters of natural cycle.
Natural cycle.
So whenever we can, we go with the natural cycle. And we published a paper, Ashna Bayram is the first author last year, 1.5 years ago, with single embryo transfer after genetic testing. In a natural cycle, ongoing pregnancy, 75%. With HRT, 64%. Okay? So we have 10, in our hands, we have 10% difference. But the natural cycle is very difficult to do because you need to identify the exact timing of ovulation.
Yes.
You need to understand when does progesterone go up. And this is the shortcoming of many studies comparing natural cycle with HRT, because simply you cannot put a stick in the urine and say, okay, she's ovulating and inshallah, we're going to transfer in 5 days. No, that doesn't work like this.
So when is the best time to convince that, well, ovulation will come in the natural cycle?
So again, Barbara Lawrence from our group published a review article describing this. The title of the paper is Natural Cycle, How to Do It Right. So simplifying, you have an LH rise. When you have an LH rise, the second day of ovulation, you have a drop of estradiol. The third day of ovulation, you have a progesterone rise. So the moment you have this drop of estradiol, increase of progesterone, between 1 and 1.5 nanogram is considered day 0. Okay. And then from there, you calculate your 120 hours.
And do we need the progesterone supplementation in natural cycle?
So if you read the publication by Ariel Weissman, they will tell you yes.
Yes.
Published in Human Reproduction Update, they will tell you yes. I will tell you no. And I will tell you why. It's based on the patient's profile. So we are running a study currently. We're running a study where one group, it depends again on the estradiol level in the follicular phase. So women who have high level of estradiol in the follicle, even in a natural cycle, because you can have a woman in a natural cycle with estradiol of 250 or 300, or you can have a woman with estradiol of 150 or 180 where she ovulates. So if the estradiol level is high, most probably she would benefit from a luteal phase support. If the estradiol level is normal, you don't need that. But again, we are running a study currently, randomized controlled trial, one group luteal phase support, other group no luteal phase support. I was checking last week, we have included 80 patients. Up to now, there is no difference, but we have to continue.
Okay, very interesting. Any question? Yes, please, Dr. Susan. Microphone, please.
Okay, for to the transfer of the frozen embryo transfer. For the PCO patient, sometimes you are very difficult to find a very good endometrial. Are you prefer doing with HRT or do the stimulation and maybe the mild stimulation for the transfer?
I was hoping you would not ask this question. No, I'm joking. Look, it's a very important question you're asking. First of all, easy would be HRT. It's easy. You do HRT, you put back. The problem with the HRT is you have no corpus luteum. And recent studies, Frauke von Hünk from Germany published some papers, Griesinger published some papers, we published some papers. It seems that if you have a lack of a corpus luteum, you have a lack of many factors, like relaxin, like vascular enteral growth factor. And this lack seems to have an impact on the vascularization of the placenta and has an impact on preeclampsia and hypertension during the pregnancy, right? So this is why we always prefer to to have a corpus luteum. So how do you have a corpus luteum? You do a mild stimulation. It's funny because there is a debate. I'm invited to speak in Spain, I think in 6 months, where I have to tell exactly the opposite. I have to say, you have to go for HRT and no corpus luteum. So this is the fun of it, to convince people of the opposite, actually. But if you ask me, you need to have a corpus luteum. So if you can have a corpus luteum, it will be much better because it's a healthier pregnancy. And you know, I don't know if you're aware of it, currently, Samuel Santos Ribeiros from Portugal is developing a new concept. It's a semi-natural cycle, because the problem with the natural cycle is to capture the ovulation, LH rise, and so on. So it's too time consuming, coming, going, and so on. So what they do, they go for a natural cycle. And in fact, when the patients have an endometrium of 7-8 millimeters without ovulation, they just give progesterone. And then they transfer. And they published a paper recently, and Griesinger did the same, similar findings. They seem to have good pregnancy results, and they seem even to create a corpus luteum with just giving the progesterone, which is an interesting concept.
Yeah.
Thank you.
Thank you very much. So one last question about the concept of individualized luteal phase support. So what do you think about that?
So this is a very important topic, which is linked to the E2 levels. So currently, I think obese women, because they have aromatase activity, they have progesterone receptor resistance, adenomyosis women, endometriosis women, women with high levels of estradiol in the luteal, in the follicular phase, they would benefit from intensified luteal phase support. So those patients, I think they would even benefit from intramuscular progesterone. But all the other patients, I think normal vaginal would be enough.
Okay. Okay. Thank you very much. I think because
you.
the limit of time. Thank you very much, Professor Fatemi. Good afternoon, everyone. Thank you.
Thank you, Prof. Iko, for leading this second session, and also to Prof. Fatemi for the valuable knowledge and insights. Kindly remain on stage to take a group photo.